little bit about what I call a living laboratory in Rhode Island, an experience that we're having here, pulling together the things that I've heard in the last couple of days: leadership, persistence, laser-like focus on the patient. I think those things are happening in a really unique way. I don't think it's the only way to work our way through transformation, but we're pretty excited about the results that we're seeing. So I want to talk a little bit about, we are a health information exchange. And yesterday when I heard about persistence, it made me smile, because in the beginning of health information exchanges, we worked with them for about 1.5 years before we started evaluating their effectiveness. And people said, oh, they're a failure. Darn, this was such a good idea to maybe make the data liquid and follow the patient and be able to have it whenever we needed it. In fact, we look at the Economist magazine ranked healthcare second only to mining for lack of investment in information technology. And we can, we love technology. We can look in every molecule of your body. We just can't get your lab test across the street, even if your life depended on it. So the HIIs were this idea. And then they started to evaluate them very early, and gee, how disappointing. They're not really doing whatever they wanted us to do, which was reducing unnecessary testing, duplicate testing. We didn't see medical error go down. And I thought at the time, sitting there on a panel where someone was revealing their research on this, and I thought, oh my God, it's almost like we're evaluating a 9-month-old baby crawling around on the floor, and we're saying, what a huge disappointment. This thing was supposed to run, jump, play Little League, do all these things, and it's just running around drooling. It's on the floor, it's not even walking. And we're not putting any more food into this thing because it's clearly a disappointment. And I thought about that and how long it's taken us in Rhode Island to be able to pull together this idea that the data flows into a central repository in Rhode Island across geographic, proprietary, payer boundaries, no competitive boundaries. You can be homeless today, tomorrow in Medicaid, the next day in Blue Cross, it doesn't matter. Next day in Tufts, your data flows into a centralized system. And we did that because we kept the patient as the North Star and we persisted. I think there's real value in it, and I want to share with you some of that value today. 95% of all lab results flow into the central repository. We have behavioral health. We're one of the few places in the country that can upload data from 42 CFR Part 2 facilities, so alcohol, substance abuse data flows in. Long-term care facility data flows in, the VA is connected. Those types of things are critically important for building a clearer picture of the experience of the patient. And I want to tell our story a little bit through the lens of the opioid crisis, because I think it's decimating a generation. And I think that when we look at this as drug mortality in 2005 and what drug mortality looks like in 2014, we've got a big crisis on our hands. That's 2014. It's worse. It's worse now. And most of you remember the iconic picture that went viral of the face of the opioid crisis. And I showed this during a presentation, and somebody that I love very close to me came up after me in that presentation, sought me out and said, please don't do that. That's not the entire picture. You're not telling the whole story. I really wanted to show this because I wanted for us to understand we're not just decimating the generation. Look at the child in the back seat, the 4-year-old in the back seat. It's more than one generation that's happening here. And I'm thinking this is a lack of collaboration, a lack of wrapping our arms around the patient. So I wanted to show that. And she's really dear to me, and she said, I think that this almost paints it at the margins, this particular photo. It's easy to dismiss it. Our society will dismiss that set of photos and say, unfortunately, a couple of people made a really bad decision in their life, reaping what they sow. Then I started to raise my head and look around things like, how is this crisis affecting us? This is Kelsey Grace Endicott, 23 years old, dead of an opioid overdose in Massachusetts. Kelsey's mother wrote one of the most touching eulogies to her daughter and then posted it online. Thank goodness, because I think it was educational and illuminating. And she said that these people are deeply valued, loved beyond belief. She said, Kelsey didn't want you to cry for her. She wanted you to fight for her. I'm not sure we're fighting for this generation. I'm not sure we're connecting to purpose enough. Sometimes I think that when we listen to debates like last night, we think that it's just absolutely impossible to change this healthcare system. And then I think of one disruptive incident, like Creighton Christensen has taught us, that there can be a disruptive something that catalyzes change like never before. I'm hoping to God that it's the opioid crisis. So when I think about what we're doing at the Quality Institute, and I think about how the problem that we set out to solve there was this idea of information flowing back and forth or not. So sticky notes and garbled phone messages and snail mail and the inability to get tests so we repeat them, the inability for us to understand what medication was given over here so we give one that interacts, creates a side effect, and so we give another medication to deal with that side effect, and on and on and on. It's really a sad legacy when I think about the fact that we wouldn't, I was driving through Wendy's, which I should never admit at a healthcare conference, especially when we're talking about health today, and the order's coming up on the screen, and I'm watching it and I'm thinking, my God, there is more technology in getting my biggie at Wendy's than there is in getting my cardiac medications to patients before we started into the IT work. Something's got to change. This is a catastrophe. So we set out that idea of connecting the system together. And I really thought that if we did that, we would work our way out of the problem of inefficiency, that we would be skating to where the puck was going with value-based payment. That, my understanding of value-based payment, as I thought about it back then, was that one of these days we're going to have a limited amount of dollars to take care of a population of patients. Now today that we see that reality, and we know that if you have an ACO, at best, you probably have 30% leakage, meaning 30% of your patients go somewhere else. That idea of not having the information about where those patients go and the care that they're receiving will doom you under a value-based payment model. We have to understand that. We also know that harm continues. Those of you that know me know that I gave a catastrophic overdose of a dangerous drug to a 7-year-old child. And I did so really early in my career. It was such a huge lesson. In many ways, it was a gift that I didn't want, but I was given that gift. That medication was hand transcribed 7 times before it was given to me. I think back on that and I think, what a horrendously designed system. Well, we still have that today. And so I want to set out with this work in Rhode Island, this living laboratory, to redesign that at a system level, to understand that what we need to do now is to create centralized opportunities for us to connect in once. I see lots of places trying to interoperate, meaning that they're all going back and forth, and they all want to put integrations with every other person in the community. Man, think about the waste. We're hardwiring fragmentation right straight into the future with that. This idea in Rhode Island is you integrate once, and then you can have the data from everyone else that sends the data back into you in Rhode Island. One integration, that data comes back to you. It's really exciting. The problem is it didn't address the issue. I thought it was going to. I was speaking at the Patient, Practitioner, and Computer Conference at Brown, and I was thrilled because I thought I was going to be able to talk about all the value of current care, our health information exchange. One of my most trusted and revered friends of mine, a physician cardiologist, said, Laura, I think your heart's in the right place. You really want to do well here. But what I feel from this, and I want you to understand, is that I'm looking for a little needle in a haystack, or maybe a couple of pieces of hay. And here's what I'm getting from you. You keep adding hay to the haystack. More data flowing in, more data flowing in, more data flowing in. So you've centralized all of that. It's not usable to me. I can't possibly do that. And you know what? We're going on for more, because here comes never offline. The idea of wearables, the idea, and you feel this onslaught of more types of information that will need to flow in to get a complete picture of the patient and their situation. Wearables are going to be a part of it. But I hear entrepreneurs always talking about, I can't penetrate the delivery system. I can't go out to every doctor in this cottage industry and try to sell my system in. And of course, if you go to the Palooza events, all of those entrepreneurs are up there and they're so excited. They're spitting all over the microphone and they're saying things like, the most awesome thing about our app, yeah, it'll measure every time, I don't know, your stomach growls or whatever. But our app, yeah, we can port the data directly to your doctor. The doctors look suicidal. They look like, you have got to be kidding. I do not want all that data ported to me. When I think about a health information exchange, that is one place that data can come in. That data on things like weights. We can monitor it 24/7, 365. If you tell us that you want to be alerted when your patient's weight goes up 7 pounds in 2 days, we'll do that. And we'll let you engage in their lives rather than the idea of they're going to engage with us in the delivery system. Because once that weight goes up, you can get on the phone, you can alter their medication. That patient will be home with their family on Friday night and not drowning in their own fluids in one of our EDs. So when I think about where we're going with this idea, we now too understand that patient-loaded data is a really critical aspect. When I spoke last time at Transform, I told you about my breast cancer experience. When they began to anesthetize me to remove my right breast, I think they thought I was having a seizure because I was going, "Ugh." What I was trying to let them know is my advance directive that I actually brought to the, I work in medical error every day of my life. I'm really aware of it. So I brought my advance directive. Where was it? Nobody asked me for it. It was a piece of paper in my purse, folded up, put in a cubby. Who knew it was there? Nobody but me. When I woke up and got my bearings after anesthesia, I thought, what are you doing? My breast cancer was a gift beyond belief because it allowed me to understand what I wasn't doing down in Rhode Island. So I said, when you wake up from this, you get down there and you fix this. So patient-loaded data is the next thing that we're beginning to do here, is to allow them to bring what's most important into them. We now know that it's going to get worse in the sense of social determinants of health will come into our database. We want to be able to know if someone in the family's lost a job, perhaps the breadwinner. Somebody has just been incarcerated or just come out of the penal system. Somebody else has got a child in the child welfare system. You're in a zone where we know that about 80% of the people there are using state services at a high level. That puts you at high risk just in terms of the neighborhood and the areas that you're living in. We want all those things to come in. We want that patient-loaded data with the wearables, and we want claims. We want to have one of the most comprehensive databases upon which to overlay things like artificial intelligence. Whenever I read about the promise of artificial intelligence, I also always hear about the Achilles heel. What's the Achilles heel? Access to data. Come and get it in Rhode Island, because we're going to have a wonderful place to experiment with the real power of artificial intelligence. So when I think about all those things being incorporated into that now, yeah, probably from the provider's point of view, it's only going to get worse. And it is. So we've got to begin to think about sift and serve technologies. How do we reach into that database, pull out only what's pertinent, important for both patients, families, providers, everyone that depends on this system, but particularly because of this problem. The right hand still doesn't know what the left hand is doing unless we use this data in a way that makes that connection happen. So what we've done in Rhode Island is we now, this won the 2017 Providence Business News Innovation Award about 3 weeks ago. It's a dashboard that any nurse care manager can sit in front of and understand in real time anytime her patient is admitted to or discharged from any hospital or emergency department in the state of Rhode Island, regardless of your affiliation. So they can see what the diagnosis is. They can look and say, that's my congestive heart failure patient. Are they there for congestive heart failure? No, they just cut their finger chopping carrots. All right, I can move on to someone else. Do you know how much time is eaten up in somebody just finding that out, if they ever find out you were admitted? Sometimes they don't even know. Patients will come in and they'll say, gee, Myra, how's Joe? Joe passed. Oh, he did? Gee, we've seen Joe for 30 years in our practice and we didn't know he was dead. So these types of alerts have enormous opportunity. So we've heard from our providers that they'll sit there almost overcome with emotion when they talk about the time this is freed up. One talked about seeing a patient of theirs pop up on the screen. They knew she was alone. They knew she didn't have a family. They raced to her side at the hospital. They were there holding her hand when she passed. She had no one. But she did at that moment because of something like this, where we can begin to link the community together, make those connections that are critically important. So when I think about this for the opioid crisis, here's the situation. When someone comes in with an overdose in Rhode Island, oftentimes the opioid treatment center doesn't even know they've overdosed. Neither does their primary care provider, neither does a specialist, neither does the community health center. And when they come into the emergency department, they don't know anything about the patient either. They're sitting there trying to treat the patient in an emergent circumstance in an information-free zone. So what we've done with our dashboards is that the opioid treatment programs now have them. They know in real time when their patients are going in and out. They can catch them in that golden window of willingness right after that overdose. The community health centers have these dashboards. What we're going to be launching in 2018 is when that patient hits the ED. It'll reach in automatically into current care, into that now giant database. It'll pull out any of that information about the opioid circumstance and serve it up right into the Epic Tracker board with a little icon. They can click on it. They can look to see, all right, this patient has overdosed 3 other times. It's been here, it's been there. And by the way, they've had these prescriptions. That information will come up in real time for them. I want to overlay artificial intelligence on top of this. So what a primary care doctor now looking, David Eddy's comments were never more poignant than they are now. that the complexity of modern medicine has exceeded the capacity of the unaided human mind. It has exceeded the capacity. I want that AI to be able to reach into that patient's record that's now enormous, synthesize things, pull it out and say, from everything we see in this record, this patient may be in the last 3 months of their life, might be time to have the conversation. This patient may be pre-diabetic. Do that synthesis for us, serve us up. And so when I'm thinking about here, the real-time dashboard, the one thing that we're most excited about is we've now turned these toward the patient. The patient can access their longitudinal record, view, download, transmit. They can designate somebody else. 80-year-old person wants her daughter in Pennsylvania to know if she's been admitted to or discharged from a hospital. That can happen. Somebody who is sending their child to Brown University, you want to know if your kid's been taken to the emergency room, they can designate you. But more importantly, I spoke to a mother of another young person who died from the opioid overdose. I wanted to be sure that I told her in advance about this new innovation where when they're in treatment, they can designate a family member to know. This particular person's son overdosed 7 times in the last 3 months of his life and 3 times in the last week of his life. And during that time, he was treated and treated each time. When you're in an emergency, you're busy, you're saving the patient's life. They actually treated and treated him, put him right outside the hospital and said, go. It's what we have to do in those emergent circumstances like that. They had no one. But now she can get that. She could have gotten it had we been more timely in delivering it. She said, when I gave her that information, she said, wow, I think I would have had maybe 7 chances to save my son's life. And then she said, no, I don't know. I don't think he would have overdosed 7 times. It's the connectivity. So what I really want you to see here is that real outcomes, absolutely. 10% lower 30-day hospital admission rates and another 19% ED readmission rates. We don't necessarily want to be current care the brand, we want to be current care inside, meaning that we will be able to feed this into just seamlessly. I don't care, we don't need the brand name, the fame. I want to put an Alexa on top of this thing because I want to be able to have a physician keep their hand on the shoulder of the patient and that eye contact with the patient and just query this database for whatever it is that they need in that moment. So we see the promise of all of this, but I want to just wrap this up with the longest 3 minutes of your life. When you look at the faces of the opioid crisis in Rhode Island, these are pictures that parents and family members have posted, and I just want you to see. If this doesn't catalyze us to cooperate, I don't know what will. As a mother of an 18-year-old son, I can't imagine the anguish. I want this to be the catalyzing thing that finally causes us to cooperate, that finally causes us to understand things like that the opposite of addiction is not sobriety, it's human connection. We can be part of making those connections. We must be part of it. We do all die. The goal isn't to live forever, but it is to create something that will. We want to close the gap between what we do and why we do it. I think it's the only way out. Thank you very, very much.